Well, we're approaching 2 minutes after 2. I think it might be good to get started. Good afternoon, everyone. My name is Dr. Bill Keck. I'm chair of the Council on Linkages, and it's my pleasure to welcome you all here this afternoon to this meeting of the Council. One other thing, you may have noticed that we're joined by one of our old partners, Kathleen Amos, who's the council's assistant director, has returned after maternity leave. She has a bouncing baby girl approaching a year of age now, I think. We're delighted to have her back with us. Myella, if you would, while I'm thanking the CDC, National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce. It's a mouthful, but I want to again recognize them for their continuation of funding for the council's activities. What we are doing would really not be possible without their participation, and we are grateful for that. And Myella, if you would perhaps go over the housekeeping items today.
Absolutely. Thank you. Audio is available via computer or phone. We ask that you please keep yourselves on mute when you're not speaking. Please feel free to have your video on, to put comments or questions into the chat at any time, and to open your audio line to speak during discussions. We are recording this meeting. We use the recording for note-taking purposes, but it will also be shared publicly. We do have some new enhanced security features that allow us to pause the meeting and all participant activity if necessary. If we do need to use these new features, all screen sharing, audio, and video will be suspended while we work to identify and remove bad actors from the meeting. Once they have been removed, the meeting will resume. So while we hope we don't need to use this feature, we ask that you please bear with us as we will be working as quickly as possible to resume the meeting as planned. And as always, if you have any questions or technical issues, please feel free to send me a message in the chat box.
Okay, thank you very much, Myella. As usual, I think we like to remind all our council members exactly what our mission is, what we're here doing, and it's particularly important during one or two of the items for today's meeting. So remember, our mission is to improve the performance of both individuals and organizations within public health by doing what we can to help develop collaboration among the academic, practice, and healthcare communities, by promoting public health education and training for health professionals throughout their careers, and developing and advancing innovative strategies to build and strengthen public health infrastructure. As you know, we now have 24 national organizations as members. We're delighted to have all of them with us. We are staffed by the Public Health Foundation, and we focus principally on workforce development initiatives that we hope will broadly benefit the public health and population health workforce. The agenda for today's meeting, you've all had a chance to see. I hope you've taken the opportunity to review it. You'll know we have the usual action item of approving minutes, but then another new action item where we'll be proposing a new effort for the council to consider. And then we'll be hearing about rebuilding the public health workforce and then updates on our major council activities. So let me pause just a moment and ask if anyone has any additional item they think should be on the agenda that we've missed. Okay, hearing none, then we'll move ahead. And as we begin, we do have a new council representative from the National Board of Public Health Examiners. He is Dr. David Buys, who is a state health specialist and associate professor with the Department of Food Science, Nutrition, and Health Promotion at Mississippi State University. And David, if you'd like to add anything else, would be happy to see you and hear a few words from you.
Thanks. It's an honor to be with y'all. And you're absolutely correct. That's my title and my day job. But I also moonlight as chair-elect for NBPHE. Allison Foster's not able to be with us today, so I'll be listening with extra special attention to where our work through NBPHE might fit in, and look forward to being a part of this group, at least for the next year, if not for beyond that. We try to build linkages. I think it's a great opportunity to learn more from other organizations, and I don't think a lot of fields do this kind of thing. So it's exciting to know that this is happening in public health. Thanks for letting me be a part of this.
Absolutely. We're delighted to have you. And you can get in touch with us anytime you have any questions about what's going on, and would invite you to take a look at the website at the Public Health Foundation, look at the council's website. It'd be an opportunity for you to review and catch up a little bit on what's been going on. But welcome to the group. We're delighted to have you.
Thank you.
You've all also now had a chance to review the minutes from our last meeting, which was September. It seems like a long time right now. It's September 26th. So let me begin this process by asking if we can have a motion to accept the minutes as presented to you.
Chair, I wish to move the acceptance of the minutes with appreciation for their accuracy and detail.
Thank you, Dr. Gilmore. Do we have a second? Of course, I'm asking council members now. Someone second the motion for us, please?
This is Sue Swider from AACN. I second.
Thank you so much. All right, now let me ask if there are any additions or corrections that anyone has. Hearing none, then let's take a vote. I think perhaps the simplest way to do that is just to ask if anyone objects to accepting the minutes as they've been presented. Do we have any objections? Hearing none, then I'll just declare that the minutes have been accepted. Thank you all for your careful review of them, and we'll move ahead. We want to ask Kathleen now, as a way to welcome her back, is to give her a chance to talk to us about something. So Kathleen, if you would, fill us in on what's going on with the CDC Cooperative Agreement application.
Sure, thanks, Bill. And it's great to be back. This has been like almost a whole year, I think, since I've had a council meeting. So it's nice to see you all. We wanted to just say a few words about our cooperative agreement with CDC. So as many of you may know, the funding that supports Council on Linkages activities comes from CDC through a cooperative agreement with the Public Health Foundation. And that current cooperative agreement that we're in is set to end July 31st of this year. So we are currently in the process of applying for a new 5-year cooperative agreement that would start August 1st. So we're hoping to keep things rolling. At the end of January, CDC did issue a notice of funding opportunity for this new cooperative agreement, which is strengthening public health systems and services through national partnerships to improve and protect the nation's health, and so the idea behind this cooperative agreement is for national organizations to provide capacity building assistance to improve the overall performance of the public health system. So proposals for that are due April 1st. As I mentioned, we're working on ours now, and we'll keep you updated as we go, as we learn more about the results of our application, probably over the summer. Does anyone have any questions or comments, anything they'd like to share related to that?
All right, thank you so much, Kathleen. We all have
Thank
our
you.
fingers crossed, I'm sure, that this will be a successful application. We're kind of expecting it, aren't we? So let's move on then to Ron, who's going to introduce the idea of establishing a retention and recruitment learning community. So Ron, the floor is yours.
Great, thank you so much, Bill. What Kathleen also did not mention is that in return for her returning from maternity leave, she's our lead for the proposal development as well. So we decided it was good to really get her going as soon as her foot was back in the door, right, Kathleen? Okay, so we at the Public Health Foundation, we do a variety of presentations. We get lots of communications correspondence from health departments, and we've heard from a number of health departments in our travels, both virtual and really now in person. We've heard from a number of people that creating a retention and recruitment learning community to facilitate the sharing of ideas and collaborative learning would be really valuable to our community because there's a lot going on in this area. And so while thinking through how we go about setting up this learning community and its focus, we've also talked with partners such as ASTO about what they're doing so that what the council does is a value add, not duplicating somebody else's effort. We certainly don't need additional duplication in our field. So having said that, let me turn it now over to Maëla to talk about the proposal that we have for establishing the retention and recruitment learning community through the Council on Linkages. So Maëla, let me throw it to you.
Great, thanks, Ron. So you may have noticed that we flipped the way we're suggesting to address this issue of retention and recruitment. The rationale for the switch is to place a greater emphasis on retaining staff, which ultimately can limit the need to recruit new staff. So as we began thinking through how a learning community can be helpful to our public health community, we considered what we've been hearing from the community, such as the desire to share and learn from one another, and what is not being addressed by others through a similar type of learning community. So we propose that the learning community focus on issues related to organizational culture, workplace environment and employee experience, human resources, processes, and benefits, workforce pipelines and extenders for recruitment, and of course, to make connections to the academic health department learning community. You'll notice that salary and civil service requirements are not included on this list. We think it's best for this learning community to focus on what health departments control and provide tools and resources that are practical and allow health departments to take action to address retention and recruitment. Issues like salary and civil service systems are often outside of the purview of these agencies. And in addition, there are other organizations working to address salary needs and civil service requirements. Next slide, Kathleen. So similar to how the academic health department learning community was formed, we believe it's important to form a retention and recruitment work group to help us further refine the purpose of the learning community and help us to ensure that what we are planning to develop will be a benefit to the field. In addition, the work group would review materials and help with determining the format and topics to best meet the needs of the audience of the learning community. So maybe now would be a good time if you have any questions or comments, or Ron, if there's anything else you'd like to add.
Nothing more from me. Love to hear from Council on Linkages members.
So, any questions or comments? Does this seem like a good idea?
It's
So Bill, there is a
definitely,
hand up. Erica Smith. And then there's Terry.
Hi, everybody. Yeah, can you hear me?
Yes.
Great. My name is Erica Smith, and I'm the acting state EPI for Delaware, as well as the Council of State and Territorial Epidemiologists representative for the Council of Linkages. And I guess I'm really glad y'all are focusing more on things that we can control, because I think there's a lot about the current job market that we simply just cannot control. And one thing I would also encourage you to think about, if you haven't, is workplace policies and procedures around actually documenting and succession planning for staff. I have found that while we can't necessarily control when people come and go, what we can control is making sure that when the new employee comes in, they at least have a plan of action for the position, and they have good documentation from their predecessor so that they can hit the ground running when they're new in the position. So I don't know if that's outside the scope of what you were thinking, but that's what we're focusing on in my agency, more so than recruitment and retention, because things like salary, as you mentioned, are so far out of our control. And we find that that is the main driver and we can't control that. So we're trying to explore other avenues.
Mayella, perhaps you would want to say something about the work group. Oh, I'm sorry, it was Gary next. Excuse me, Gary. I jumped in, excuse me.
Bill, I think Terry, Gary, and then Rex, looks like.
Hey, thanks, Ron. No, just a quick comment. This is speaking from NACHO's perspective of local health departments, this is a huge issue. And just not in rural areas and just not in small health departments, but across all of our health departments. And it's very encouraging that we're launching into this area in an organized way, so that we can, we can assist those health departments in not only recruiting health staff, but also retaining them once there. So a big thank you for moving in this direction. We certainly support it.
Dr. Gilmore, I think you're next.
Thank you. I just wanted to state strongly that this is a step in the right direction in this day and age, and I'll state it simply and succinctly in that manner.
Thank you.
So I don't know that I can do it as quickly as you did, Gary, but I support this approach. But I will say that, you know, the fact that we believe that salary is still, if not the most important, one of the most important, I think we've got to figure out a way to be thinking about that. I remember when I had a crisis with environmental inspectors and we were paying less than incoming high school grads in the police department for just administrative work, and we were requiring a bachelor's degree with 30 hours of science. And if we didn't change that, we would not have been successful. And there are strategies that you can change some of those things. And hopefully some of this other work may also tie to ways to help folks make those salary arguments down the road.
And if I may speak to that for just a moment, Rex,
Yeah.
you know, part of our thinking also is that there are some other organizations working on the salary issue, the advocacy issue, as well as even the civil service system. So our thought was, you know, again, what is it that we could do that would be unique and also needed? I suspect there's no way to totally avoid some of the discussions about salary and ways of what agencies do that influence that or could influence that.
And one comment I had when I was rudely interrupting people, Mayella, is you mentioned that the way forward for us, usually the first step involves developing a work group. Have you thought about saying anything today about how that work group will be constituted? In other words, if people on the call are really interested in this and want to join us, this might be an opportunity for them to have a fairly central say in how this evolves.
Yes, absolutely. If there is anyone on the call today that is interested in being a part of the work group, or if there are folks that you know of that, you know, could be really great at sharing their expertise in this area, please feel free to just send me an email. We're thinking we will probably put out a call for work group members once we decide that, you know, we wanted to move forward with this new learning community and work group. But yes, if there's anyone that's interested, please just let me know.
Do we have
Bill,
other...
I see Lindsay has her hand up.
Good.
Hi, thank you. Hi, everyone. I'm Lindsay Myers. I'm new to this group. I'm ASTO's Vice President for Public Health, Workforce, and Infrastructure. And I know that PHF talked with our team about this concept, and we're certainly quite supportive of it moving forward, but did want to just highlight that it does complement a lot of the work that's happening in our agency through our workforce peer network, and also our public health hero learning community that has 13 jurisdictions currently participating, and some of the the purposes or focus areas around organizational culture and some of these things are very similar. And I think it's just a great opportunity as this moves forward for some cross learning. And we would certainly be happy to participate in the work group to share what we know so far, and that might help further sort of see where this group might be able to go beyond what our current work is doing in this area. So I just wanted to mention that.
Thank you. Are there other comments or questions? Okay, well, hearing none, then let me suggest as a way to move this officially onto the council's agenda for work, I'd like to entertain a motion from someone that the council begin the process of establishing a retention and recruitment learning community. Do I have that motion?
So move.
Second.
And a second?
Second.
All right, thank you. In order to simplify this, let me again suggest, unless there is objection, that I just ask if there is any member of the council or official designated representative for the council who objects to us moving ahead. Are there any objections to moving ahead with beginning this process? Hearing none, then let me just declare then that I believe the council has agreed that this idea is worthy and we should begin. And the next steps then will begin to formulate the work group and formalize at least the initial suggestions we have from staff. So that will all be refined, and I'm sure, Maela, in future meetings we'll get reports just like we have from the Academic Health Department learning community. Thank you. This is very exciting. Thank you all. Then let's move on then. Ron, if you would.
Back to me again, huh?
Yes, it's you again.
Yes. So I'm really excited about this portion of the meeting. Since 2021, it now seems so long ago, since 2021, because of the renewed focus on the public health workforce, we've included in Council on Linkages meetings a segment on rebuilding the public health workforce. It's really been quite important. And of course, the academic and practice perspective here and expertise helps us address this. Today, we're particularly delighted to have with us representatives from 2 health departments who provide us with examples of how the work of the Council on Linkages is contributing to their workforce development efforts. First, we'll hear from Brenna Davidson, who is the Operational Excellence Leader and Chief of the Office of Performance Management for Missouri's Department of Health and Senior Services. Brenna leads the agency's Lean Six Sigma Strategic Planning and Information Technology Advisory Committee teams, which while working on to maintain Missouri's public health accreditation through the FAB accreditation process. Brenna has a passion for continuous improvement and change management, which she uses to collaborate with team members across the agency to develop innovative initiatives and improve workforce culture. So she'll talk about the Missouri experience. Following her, we'll then hear from 2 of our colleagues from the City of Milwaukee Health Department. We'll hear from Kiki Lezama, who is the Director of Public Health Workforce Infrastructure at the Health Department and works on building the public health workforce of the future focused on health equity and racial justice. Kiki is passionate about systems change, focused on dismantling systems that perpetuate health and racial inequities from the organization to the community level. She's dedicated to elevating voices of the community and creating inclusive environments for all. Further supporting this passion, Kiki began her doctoral studies, so working full-time and pursuing her doctorate. That is a commitment, pursuing her doctoral studies of public health in leadership, advocacy, and equity at Tulane University. And also from the city of Milwaukee, we'll hear from Lindsay O'Connor, who is the HR administrator for the health department. And Lindsay has 22 years of experience in human resources in a variety of industries, including the past 2 years in public health. Through Lindsay's work, she has written organizational policies from a racial equity lens and changed the organizational culture from punitive to one of understanding and inclusion, meeting people where they are, something incredibly important for all of us today in all of our organizations. So without anything else that I say, let me turn it over to Brenna because you really want to hear from our presenters. Brenna?
Thank you, Ron. If we can go to the next slide, I've got a couple slides for you. So I am Brenna Davidson. I'm the Operational Excellence or OpEx leader here at the Missouri Department of Health and Senior Services. As my bio says, our Office of Performance Management houses our accreditation team. So that is where I overlap with the workforce development world. I do moonlight in workforce development and organizational health initiatives. So just like to say that I'm very excited to hear that you guys are starting a new learning community. And I think some folks here in Missouri will be definitely joining and listening in on those conversations. So if we can head to the next slide, I'm going to pull it up on my other screen too, so I can keep myself on track here. I'm going to tell you all a little bit about our approach to workforce development planning. We were on a very, very short timeline to finish our FAD reaccreditation application just this past year. And we reached out through ASTO. We're big fans of ASTO, and they've helped us a lot in the past for assistance. And they said, hey, the foundation is really the place to go. And so we reached out to Ron and his team and realized that timing and contracting processes and funding was going to be a constraint for this project. So luckily, exciting to know that the FIG or Public Health Infrastructure Grant technical assistance available through the 5 system actually supported our connection to working with Public Health Foundation. So we're eternally grateful to our CDC partners for that opportunity. So we were able to work with the best of the best to have a plan that is really much stronger than it ever could have been without the help. So part of that process is that we adopted your council on Linkages Core Competencies as a framework to organize our workforce. So we incorporated the core competencies in the past, but not in the way that we have since. So we started with some job categories you see there on the right side of your screen. We had some meetings with leadership to determine these job categories because it's not so easy to fit 1,900 FTEs into 6 perfect little boxes. So we really debated on what these should be and what they could be too. We are not considered a super agency, but we do have senior services within our purview, as well as cannabis regulation, state health, public health laboratory. That's pretty standard, but we do have some regulatory entities that are a little beyond the regular public health scope. So we made sure that these categories included folks that do customer support and human services, as well as our classic public health work. On the next slide, we're going to talk through a little bit of the approach that we followed. So this is actually the graphic I used to communicate to team members about what we were undertaking. So under the guidance of the foundation and the FAB requirements, we broke it up into very simplified phases here. We created those job categories in the first phase through leadership, and then sent out invitations through our senior staff folks to say, hey, we need at least 3 people per division. We have 6 divisions and a director's office to attend these interactive workshops in phase 2. And so those would be, okay, we need 3 data scientists from this division and 3 from this division to get the workshop attendees list. And then the PHF folks that we partnered with, that I'm going to call out on our last slide through appreciative work with them, they actually did the facilitation of those workshops that taking that off of our plate was such a blessing for us, because they really were able to explain the core competencies in a very accessible way, that this is new information for our team members. They did not realize what this framework was or what they were getting into, basically. So we did some education around what the core competencies are and the process itself. Those workshops, they said, okay, everyone in this room, virtual room, is a data scientist. So which of the core competencies are most important to this role? And they picked, there's a perfect setup that the foundation has to rank them. And so we use those workshops to have the definitive ranking of representatives from each category, said that these are the priority competencies. We took those competencies and we created an all staff survey, and that went out, and the timing was not great. It went at the same time as our statewide organizational health survey, but we still got a really great response rate. And I'll go into some details in a second about why we had a good response rate, but every team member had the ability to weigh in on how they felt their proficiency levels were for each of those priority competencies. So they said, okay, I work in data services. I'm going to click that drop down. And then here are the 8 things that we said were most important. Out of 10, how do I feel like I am capable of that? It really is a competency assessment, but we use the word proficiency to kind of, take the risk of getting folks lost in what's a core competency and then what am I rating here? So we called it proficiency instead. And then we took that information, analyzed it, and the core team behind the scene, writing the plans, actually used it to build the gap analysis to create the training plan to ensure that all the collaborative development was included in the development of the plan. On the next slide, we talk about the communication of things. So I am a communication person by heart, and I'm realizing through our reaccreditation process that if you don't bring people along with you, they don't buy into the plans. And something I learned from our peers in Indiana was a little saying called not about us without us. And so I love the way that they say that, because it's just a perfect encapsulation of the collaborative planning process. So that survey, we promoted it here on your screen. You can see, like, share your perspective to help us create a training plan that works for you, to get that buy-in, because everybody is hungry for training. They want in-person opportunities again after the pandemic, but this was their chance to actually weigh in on what they want to learn and how they want to learn it. So we created an intranet site to house all that information of why are we doing this? How are we doing this? What are the categories and the descriptions, and what do they actually mean? A link to that survey. And then we had people within our team available to answer any questions that folks had. And then ongoing communication wise, we talked about this. We have monthly department-wide town halls where about 600 to 700 folks attend each month. I spoke about, or we had senior leadership spoke about this project approach, and then we updated them once the plan was complete. We're also planning in April to have a health planning training for our senior leaders, where Ashlyn Sherman, who's on the line, who is our health planning coordinator, she and I are going to go through what are all these plans, what's the purpose, how do we want you to use them as senior leaders, and trickle them down to your teams so they don't sit on a shelf for the next 5 years until we do it again for reaccreditation. We're really living the plans, not just planning the plans. And then I also speak at new team member orientation about all of these plans. So the repetition, the key to understanding, it's always in front of them, and folks are still hearing about these things. So on the next slide, just a quick overview of our work plan, what came out of all of this work. So we have 3 main priorities in our workforce development plan: strengthen the workforce through empowerment, education, and development. That's all about recruitment, leadership development, and training opportunities. We've got ensure a competent public health workforce. That's where those competencies come back in. So increasing the skills around them and training on foundational public health services and health equity. And then our last one is position our agency, Department of Health and Senior Services, as a destination employer. So we want to be that agency that we were like, ooh, there's an opening at health, let's go check it out. So that's recruitment strategies, instilling that sense of belonging, consistent onboarding experiences, and enhanced role clarity for our team members. So the plan is a 5-year plan that is developed in the cadence of our reaccreditation cycle for FAB. This is an entire priority in our department-wide strategic plan as well. So it is linked with these large plans, and it organizes our workforce initiatives with a more strategic approach. We were kind of a scattershot, shiny object kind of approach. So this way we have a very set way that we're going to go about doing this work. And excitingly, we have the plan is published on the foundation's website as an example of a plan that has built the core competencies into the planning. And so I can drop that in the chat because I'm very proud to have a superlative plan. And then my last slide is just acknowledging the work and the help that the foundation gave us along the way. So Sonia Armbruster there, you see, she was the one that facilitated those workshops and really helped us educate our team members on what the core competencies are and why they're important. And then Amanda McCarty was our plan writing queen guru. So we did a lot of, she guided us into like what a plan needs to have to meet those 5 requirements and gave us examples of good plans. We did a lot of collaborative development. So we're eternally grateful. And I'm just really glad to be here today to share the good news that this thing is doable and there are excellent partners out there here to help. So thank you guys for having me.
Brenna, thank you so much for making this real. Really appreciate that. And then what we'll do, we'll take questions following the second presentation. And I'm going to turn it over in a moment to Kiki and Lindsay, who are going to be talking about something a little bit similar, but something a little bit different. In that in Milwaukee, they use both the core competencies as well as the racial justice competencies. So let me turn it over to you now, Kiki. I think, Kiki, you were starting it.
Yeah. So hi, everyone. My name is Kiki Lazama, Director of Public Health Workforce Infrastructure at the City of Milwaukee. So Lindsay O'Connor, who is our HR administrator, is also on the call with us today. And we are going to tell you a little bit about our new workforce initiative that we started as part of our core competency prioritization process. So it's kind of evolved to be this greater umbrella that houses all things workforce, including the core competency process. So workforce is an acronym. It stands for Public Health, Occupational Readiness, Centered in Equity. Lindsay, anything else before we go forward?
No, you've got it.
All right, next slide, please.
So why are we here? This work that we're doing is emerging from the FIG grant that we also were recipients of, lucky to receive. And we're really working towards a Public Health 3.0 framework. And so in the work that we're doing through this process and the work that Kiki is leading as our workforce development director, really will be partnering with the community, building a workforce representative of the community we serve, finding innovative paths to community engagement, and actively promoting sustainability through the effort so it can continue into the future. Next slide, please. So a little bit of history of how we got to the anti-racism framework and focus. In 2019, the City of Milwaukee was one of the first health departments to declare racism a public health crisis. And the commissioner at the time also worked with leadership to implement our Birth Outcomes Made Better program, which is our doula program, which is showing some amazing results for Black mothers and births in the City of Milwaukee. The City of Milwaukee and the Health Department joined the Government Alliance for Race and Equity as well, to start learning about how to become an anti-racist organization and mechanisms that government agencies could utilize to become anti-racist. And then we also added a public health strategist focused on health equity in that time frame, so that we could really be intentional about the work that we were starting to do in anti-racism. In 2021, our Commissioner Kirsten Johnson joined us in the middle of the pandemic, fun time, and also brought with her our Deputy Commissioner Bailey Murph, who is the Deputy Commissioner over the Policy Innovation and Equity branch of the organization, and has been extremely instrumental in really centering anti-racism in all of the work that we do. So they started the strategic planning process, and it has 6 goals. And the first goal is to build anti-racism competencies. So not only are we declaring public health racism as a public health crisis, we're then trying to be intentional, centering all of our work around an anti-racist framework. So under Bailey's direction, they did strategic planning. Like I said, there were goals, and the number one goal is building the anti-racism competencies. We have done work over 2022 and 2023 in which we've started doing work for our racial equity initiative. We started what we call caring conversations with our employees so that we can start introducing the ideas and raising awareness of the different experiences that people may have. And also we have implemented an anti-racism policy. And so that's something that the HR team is responsible for managing and ensuring that when situations are occurring in the workplace, we're addressing those things timely and also appropriately, and reporting back to our employee populations on situations that were occurring that are in the anti-racist lens. And then in 2023, we started working on the core competency prioritization along with Sonia as well, who has been amazing. And we, because of our CDC grant, we were able to put in the 5 requests so that we could partner with PHF, which has been wonderful. Next slide. So similar to what Brenna did, we categorized the 6 job categories. They're listed here. So some are similar and some are slightly different than Brenna's based on our organizational structure. We went through a similar process that Brenna went through. And because of our intentionality centered around anti-racism, we were really wondering, you know, should there be other competencies that we take into consideration besides the competency of health equity? Like, is this enough for us with the work that we're doing centered around anti-racism? So the next slide, I'm going to hand over to Kiki to talk about.
Yeah, so in this debate, when we were going through the core competency prioritization process with Sonia, just like Lindsay said, right, we knew that integrating the core competencies would be using the original 8 domains. But then we looked at racial justice competencies and said, that seems to align with our anti-racist lens, framework, and direction that we want to go as an organization. So next slide, please. That we then got into the debate of, are there 8 or are there 9 domains? And we, you know, it was, I think, a really great, needed, and timely discussion about, you know, is the health equity domain explicit enough to be anti-racist? And we realized that some organizations aren't ready to have a 9th domain, right? And we'll talk a little bit about how to maybe move towards that for some recommendations that we have. But we realized that not everyone's there. And so there is no real kind of like answer of, should there be 8, should there be 9? But for us as an anti-racist organization, right, moving towards being an anti-racist organization, we said health equity is not explicit enough. We have to use the racial justice competencies as a 9th domain. So, right, we just said that this is going to be instrumental in providing that meaningful anti-racist training and development for staff in having that diverse and representative workforce. Next slide. So recommendations, right? Again, we know not everybody's in that space to have that conversation about, is there a 9th domain? I know some organizations can't even talk about racial equity, but I think that the best way to start is having that buy-in from leadership. We are very lucky to have such supportive administration here at the City of Milwaukee. One of our deputy commissioners, as Lindsay mentioned, Bailey Murph, has been instrumental and has really led a charge in this anti-racism work. And a lot of this probably would not be possible without her leadership. So, right, you're going to have those strong players and sponsors to push it forward, especially I know that there are a lot of polarized communities, especially resulting from the pandemic. But one of the things that we focus on, especially for staff, is talking about, right, universal benefit. You always want to use positive, right, connotations if you can, but it's right the opposite of saying, right, to avoid universal harm that racism causes, right? So to help leadership in whoever is in those decision-making positions to say, hey, actually, yes, I know that this is, right, maybe a polarizing topic, but here's how racism hurts our entire community, right? Not just communities of color. And so communication with staff then around that is going to be extremely important, right? What's expected of staff, how to support, right? How our work supports anti-racism, right? And how we promote more equitable outcomes, right? And begin those introductory trainings on frameworks, shared language, values, and really with that, right, the kind of nuance of like creating a culture around that. Making a public declaration is also very helpful, right? It creates accountability. And it's also then a great platform to educate the community about universal harm, right? Or universal benefit, depending on how you want to talk about it. Because it's, right, this is something that we want obviously staff to be aware of that. But in order to sometimes get that buy-in, especially from government, right, you have to know that, hey, this is the approach we're going to go, and this is the narrative that we're going to create around us, rather than having a narrative created around, like, surrounding us, right? Like, we're going to be in the driver's seat of that narrative. I think I was saying everything on that one. Okay, next slide, I think. Anti-racism policies. So a really good thing is to have very explicit outlines and standards of what is expected from staff and what will happen when racism is encountered in the workplace. Also, things starting from even before staff is hired, anti-racism questions and interviews. So these are now included in employment interviews and also in placement interviews. We do not have a student-specific placement program. Our placements also include volunteers and shadows. It's to create a wider net of exposing people to public health. But also when they apply for those placements, they are asked about how they will contribute to the anti-racist direction of the organization. So we're starting from the very beginning. And ongoing communication, this is kind of a build on what we mentioned in the previous slide, right? We want this ongoing communication. That could be social media, that could be in what's being discussed in narrative and shared language, in who's going out into the community, right? Around anti-racism, and to promote community around it, saying, right, if one of us is not healthy, then none of us are as healthy as we could be. So that's a little line from the Minnesota Department of Health that I always pull, but that's really the essential, right, of what it is that we could try to implement all of the trainings and all of the great programs, but if we continue to ignore something as huge and pervasive as racism, we won't achieve health equity. Lindsay, anything else that I missed on that? No? All right. I think that's it. And then if you write questions, obviously, I know we planned on going second, so that's why I added that slide. But then, yeah.
Great, thank you so much, Kiki and Lindsay. And Kiki, I'll also mention that there's a short video that you all developed for your staff on the process that we also have housed on the Public Health Foundation website as an example of how a health department is using the competencies. So thank you for that. While you're thinking about questions that you have and the discussion you'd like to have, as well as other examples you may wish to share with us, just want to emphasize what we just heard. Two different health departments, one state, one local, where they're using this tool that the Council on Linkages created and periodically updates to help the workforce within the organization continue to advance, improve, and actually even serves as a motivator, is what I heard in some of the conversation here as well. And of particular note is I think we really are moving in our field from maybe years ago where agencies maybe use the core competencies as a step, but didn't quite know what to do with them after taking an initial step. The examples we just heard about are how we're using them, how we're going to continue using them, how we're moving forward with implementing our workforce development plans. And also, given the people involved here, we're also talking about continuous improvement of those plans, which is all quite exciting. So now that I've given you all plenty of time to think about questions and the discussion, let me open it up to everybody else who's on the call. Anita.
Good afternoon. My name is Anita Balan. Quickly, I represent the American College of Preventive Medicine. I'm the Director of Residency Engagement and Development at the American College of Preventive Medicine. We are in the process of identifying a representative for this very important group. So we're hoping to have a PrevMed physician from the next meeting. Excellent presentation. Thank you very much. My quick question is, preventive medicine is a recognized specialty, and it's a specialty that's trained where physicians are trained to work in clinical space and public health, and many of our physicians lead state and local health departments. So my question for both departments and both presenters is, as you are looking to optimize your workforce development, as you're looking to improve your processes, what is your feedback on, if you want somebody who is not recognized as part of somebody who is not trained based on the core competencies of public health, but if you want us to introduce PrevMed physicians or other workforce that is critical that's critical for the state and local health departments to carry out, what are your recommendations on how we can approach you and say, hey, this is another workforce, this is another segment of the workforce we want you to keep in mind, who are trained in these skills as well, in addition to or in correlation to or similar to the public health core competencies that we would like you to consider to fill the gaps, the incredible shortage and gaps that are taking place across the country. So what are your thoughts and approaches on that as you implement these work plans and workforce development plans moving forward?
Lucky friends, did you want to go first, or I can jump in if you're ready?
Go ahead.
Okay. So I love hearing that we are building that connection between the medical community and the public health community, because it's a system-wide thing. So here in Missouri, we recently, well, not recently, I guess she's been here about a year, we brought on our first chief medical officer, Dr. Heidi Miller. She's excellent. She's very preventative minded, and she's just a great energy, and she's done such a good job jumping into the public health world and understanding how we operate and how we can bridge the gap between these industries. So just want to plug that link in the chat to the Missouri plan. There's an appendix at the end. We have, I believe it's about 2 years old now, we have a workforce council that is public health and healthcare in the state of Missouri. It is something that came through a kind of grassroots initiative. We all knew that the public health and healthcare workforce was decimated during the pandemic, and we need to get innovative new ideas to create those pipeline programs and things. So the council is supported by our governor's office, but co-chaired by our department and our state Department of Higher Education and Workforce Development. That council has kind of formalized what we are working on. And so an appendix in our plan includes a progress report for 1 year of activities around 24 priorities in that council is pursuing. And they are innovative, big ideas from starting at middle school age to recruit and build that public health workforce, but also connect our associations, our primary care association, hospital, all those folks that we work with all the time with new approaches, because traditional methods aren't going to get us there anymore in this workforce world. So just wanted to plug that. But I also love the idea of building that gap between preventative health medicine and how public health is prevention. So excited to see you here and on the council as well.
Lindsay or Kiki, anything you want to add?
I think so. I'm sorry, Anita, could you just make sure, I want to make sure I understand your question. Could you say it one more time?
Yeah, so preventive medicine physicians kind of are trained to, they go through residency training after medical school, and they're the only specialty they're trained to, get public health training as well. And they have a different set of competencies, not the public health, core competencies, and very similar, but not exactly the same. So I just wanted to kind of plug in selfishly, preventive medicine physicians who work in that bridge between clinic and clinical care and public health, healthcare and public health. And so how do we, as those of us, the workforce segments, such as preventive medicine physicians, and perhaps other workforce segments, public health workforce segments as well, that you may not have come across yet, how do we ensure that you are recognizing that these additional workforce segments that also exist, like preventive medicine physicians, that can help to fill some of the gaps that the state and local health departments are experiencing, to address health equity, and to explicitly help you be anti-racist and help you fulfill the competencies that you've established as a framework. So how do we engage with you proactively and bring in these workforce segments that may not have been in the front of your mind is my question, if that helps.
Yes, no, it does. I just wanted to make sure I didn't give you a hollow answer. So I think this kind of brings back to what Lindsay and I discussed about Public Health 3.0. And so as we go into Public Health 3.0 and saying, okay, what is the role of public health? It's moving away from direct services and into systems work. In the event that that work is duplicated by somebody else in the community, we're saying, okay, if someone else is doing it, we trust you. We're going to be that convener. We're going to be that facilitator. We're going to be that gap provider. We're only going to provide that service if there's a gap. So I think in that whole transition, when departments are going through that, they should be reaching out to, these different organizations, We're not just talking about nonprofits. We're talking about the whole medical system, because we're then relying essentially on how equitable it is or not, We're relying on you all to be providers. So that collaboration is already going to be heightened, as these organizations transition into 3.0. So those conversations should already be starting to happen. I know everybody's on a different page when it comes to 3.0. But that's essentially how that relationship is being depicted, by that Public Health 3.0 framework. Is yeah, we have to work together because we're not going to duplicate services. We're not going to step on your toes. We understand that you have a scope in being able to provide, direct medical care and address, pathology, and we can be more on this end, in maybe policies, systems level work, but the talking and the collaborating is going to be that much better, because there's a lot of things that government cannot have their hands in necessarily, and so I think a lot of that systems work as the convener or the collaborator or the facilitator is going to be elevating these other community partners in order for them to do that work, because they have that ability to do that. So it's more like we're the weaving the web, and I think one of the challenges, though, that comes out of that is because now, even as we move into 3.0, it's another shift in how people understand public health to work. People already don't know what we do, They're just like, so what do you do? Do you work at a health department? So you give shots, They still don't understand, And so it's going to be that much more important for those relationships to be ongoing, regardless of where people are at in the process. Just constantly, if you have partnerships or coalitions, just constantly talking, because you never know, especially because everybody is at different levels in the 3.0 transition, you never know where that collaborative, reciprocating benefit, can happen, or when do you need to come in versus I come in. It's going to be a lot of recalibrating, just because we don't really have a great manual on how to implement that, or how to change that relationship dynamic, We're all kind of going from all right, we have this basic framework and here's how we think it works for our communities. So I don't know if that helps. That's okay, wonderful, wonderful.
Great. Other questions and comments and examples? I know there must be some out there. I didn't see a hand up. I'm sorry. Is it Medha?
Yes, Ron, that was correct. It's Medha. It was more like a comment, and I did see others adding. I think Erica has added what her public health is doing with some of the residents from the local university. I come from New Jersey, and something that we are trying to do is, or we have been doing, is allow for the rotations for the residents from our regional universities, especially residents coming from preventative medicine, programs, to come and experience the public health department and the work that we do. And I believe that I'm a primary care physician by training myself. I do see a great value in understanding our boundaries, but do boundary spanning work. It's like we come with our sets of competencies, and to really get experientially involved in these types of different projects, cross-pollinated projects are helpful. I see that is one space of learning the competencies, bringing your sets of competencies, and see where we have synergies and where we have ability to bridge the gaps. And so that's one exploration. In fact, that's one of the projects I was going to offer to one of our future residents who was coming on board. And I was going to embrace her in our CHW work that we're doing, because that is a new space that we are building, the community health worker workforce. The more that they are, they are aware of the other types of workforce also working out in the public health, they are going to better utilize it as they practice medicine, whether it's in an acute or care setting or in the community, clinics or elsewhere. So those are some ways I see as looking at it as boundary spanning work, embracing others' competency, but also keeping your specialty competencies that you bring from your, training and education.
Great. Thank you so much for sharing. Other questions and comments? One thing I will mention before we move on is that certainly we have two larger health departments here. Missouri, I think, Brenna, you said 1,900 employees. Kiki and Lindsay, I don't recall the number of employees, but you're fairly large. Or Lindsay, do you, at the top of your head, do you have a number?
Currently we have 230 employees. At full strength, we would have 340.
Wow. Wow. So you'll be doing a little bit of recruitment. So two larger health departments, but this process of prioritizing the competencies and building them into workforce development plans and acting upon them, we've seen it being used in health departments from, oh gosh, the size has probably been around 25 people, to several thousand. So it's something that is, I think, useful to all of the various organizations, regardless of the size. The process is fairly similar. You can imagine, though, grouping into 6 groups or so in a health department of 25 could be simpler, but then sometimes more difficult, because you think of all the multiple hats people wear in a health department the size of 25 as well. I see it looks like there are a couple of items in the chat. Okay, there were comments. Any other comments or questions? Well, Bill, it looks like it's time for us to move back to you.
Yes, thank you very much, Ron, and thank you to our presenters. Very, very interesting information, very helpful. And I hope you folks won't mind if we refer others to you that we learn about who might have an interest in what you're doing. If you don't want us to use your names out there, let us know. But I have a feeling you may be hearing from others who will want to pick your brains a little bit about what you're doing.
Yeah, and Bill, if I may, really, Brenna, Lindsay, Kiki have been so incredibly sharing, which they, they learn things, we learn things, and sharing it all is what it's all about. So thank you so much for all of your sharing. And Bill, I think we may even be inviting them back later to hear about progress.
Gee, you think we just might do that?
I think we might.
All right. Great. Thanks, everyone. With that, then, I'd like to call on Mayella to catch us up on some of where we are with some of our core programming. So, Mayella, the floor is yours.
Great. Thanks so much. So we're going to start with the Academic Health Department Learning Community. As you know, the Academic Health Department Learning Community is a national community that brings together and supports practitioners, educators, researchers, and others to explore AHD partnerships or formal partnerships between health departments and academic institutions. The community is designed for members to share their experiences and engage in collaborative learning. The AHD learning community is open to anyone who would like to participate and has more than 1,500 members from health departments, academic institutions, and other organizations across the country. The learning community offers resources and activities to these members and to others in the public health community to help support AHD partnerships. This includes providing a venue for sharing examples and stories of AHD partnerships, webinars featuring AHD partnerships, examples of agreements that organizations have used to formalize their partnerships, a listserv to enable communication among community members, and technical assistance. As we have done for many years, we continue to track metrics related to engagement with the AHD learning community and its resources. The learning community and its resources and tools have been accessed online more than 2,500 times since our last council meeting in September. This brings online usage of the learning community and its resources and tools since its launch to more than 86,000 visits. We also continue to provide distance-based technical assistance related to AHD partnerships. Since the last council meeting in September, council staff has responded to 16 requests, serving 16 organizations across 12 states. Our presence at conferences and webinars has also continued. AHD partnerships were highlighted during the Public Health Learning Forum and Train annual meeting held in October of 2023 in a session titled Academic Health Department Partnerships. AHD partnerships were also featured at the APHA annual meeting in November of 2023 in 2 sessions, strengthening the public health workforce, the role of the Council on Linkages between academia and public health practice, and leveraging academic health departments to strengthen public health infrastructure. We also held our latest webinars in the AHD webinar series in December and again in February. The December webinar, entitled New River Academic Health Department 10 Years In, featured a guest speaker from an academic health department who shared their experiences working to establish their partnerships and their current initiatives. The February webinar, Ask Me Anything, Academic Health Department Partnerships, gave participants a chance to ask questions and discuss their experiences developing AHD partnerships. We are in the process of planning our next AHD webinar, which will occur on April 4th during National Public Health Week. More information will be made available through the Council on Linkages update as the details of the event are confirmed. I'd like to pause and ask if there are any questions about the learning community. Okay, so as always, more information about the AHD learning community and its activities is always available through the AHD learning community section of the council website or by sending me an email, and I'm happy to drop my email into the chat again. Gary, yes.
Mayella, I wanted to ask you at this time if
Oh, no.
Gary, if you're still with us, if you can hear us, we can no longer hear you. You froze. I guess we could come back to Gary.
Sure. Yeah, we can keep moving forward and then we'll come back. Okay. Next slide. Thank you. So now I'll share some updates about the core competencies for public health professionals. The core competencies are a set of competencies designed to reflect foundational or cross-cutting knowledge and skills for all public health professionals, whether engaged in practice, education, or research. The core competencies have been around for more than 20 years, since 2001, and have gone through several iterations, the current version being adopted by the Council in October of 2021. These competencies are used in workforce development activities across the country. The most current data available show that approximately 80% of state health departments, 60% of tribal health organizations, 55% of local health departments, 25% of territorial health departments, and 90% of academic programs with a public health focus use the core competencies, and that the core competencies are being used in a variety of ways, including to guide development of job descriptions and performance objectives, competency or training needs assessments, education and training, workforce development plans, other competency sets, and other tools and resources to support professional development for public health professionals. The core competencies also appear in major national initiatives such as Healthy People and Accreditation. Healthy People 2030 includes objectives in the public health infrastructure topic area related to increasing the proportion of state, local, tribal, territorial public health agencies that use core competencies in continuing education for personnel. The Public Health Accreditation Board and its accreditation standards for health departments incorporated the core competencies into Domain 8 of the Standards and Measures for Accreditation, specifically Standard 8.2, which addresses workforce development and requires the creation of a workforce development plan that includes an assessment of current staff capabilities against an accepted set of core competencies, with the core competencies given as the example of a nationally recognized model that may be used. The workforce development plan should also include findings from an equity assessment that considers staff competence in the areas of cultural humility, diversity, and inclusion. This equity assessment could be one component of the broader core competencies assessment. For schools and programs of public health, the Council on Education for Public Health used the core competencies in developing foundational competencies for its accreditation criteria. The core competencies are integrated into the Trained Learning Network, the largest learning network designed specifically for public health professionals, so that learners can locate courses that will build desired knowledge and skills. And finally, the core competencies have long been designed to reflect the knowledge and skills needed to deliver the 10 essential public health services. Looking at the specific usage since the last council meeting in September of 2023, the core competencies web pages have been accessed over 21,000 times with over 14,000 visits to resources and tools. We also have been tracking access of the core competencies specifically since the 2021 version was released, with about 170,000 visits to the resource webpage since then. As with the AHD learning community, council staff regularly respond to requests for assistance related to the core competencies. In the same time period since the last council meeting in September, we have responded to 6 requests serving 6 organizations across 4 states and the United Arab Emirates. The core competencies were recently highlighted at Open Forum Next Generation in September of 2023 in a session titled Applying the 2021 Core Competencies for Public Health Professionals to Support Workforce Development. The competencies were also featured during the Public Health Learning Forum and Train annual meeting in October of 2023 as a plenary session titled Core Competencies for Public Health Professionals. As mentioned, the 2021 core competencies were adopted in October, and they have been available through the council website since November of 2021. Since that time, we have been engaged in a variety of dissemination activities to try to ensure the public health community is aware of and has access to the latest version for their workforce development efforts. We have also continued to work on updating and developing resources and tools that support individuals and organizations in using the core competencies. As we've shared previously, these updates began with the competency assessments, as this is the set of tools we've gotten the most requests for, and the version of these assessment tools that reflect the 2021 core competencies are available on the council website. We subsequently updated the domain definitions to describe the content of each 2021 core competency domain, and we updated a competency prioritization tool that supports organizations in identifying the most important core competencies for different public health jobs to help in determining where to focus their competency development efforts. Most recently, we released the crosswalk of the 2021 to 2014 core competencies for public health professionals to illustrate the relationship between specific competencies within these two versions. Following the crosswalk, the 2021 core competencies were made available on the Train Learning Network as a search filter, allowing course providers to identify which of the competencies their training helps to build, and as well for learners to locate training that address specific competencies. We are in the process now of developing a new resource describing the relationship between the 2021 core competencies for public health professionals, the 10 essential public health services, and the foundational public health services. We will share more information about this resource once it is available. These tools are all freely available on the updated core competencies tools page. We will continue to work to update and develop new resources and tools, and we'll share those updates through the Council on Linkages update. New resources and tools will also be posted on the council website as they are completed. At this time, I'd like to pause for any questions about the core competencies.
Mayella, there was a question that about the train session being archived.
I don't believe the train meeting was in person. I don't think it was recorded. But I believe the slides are up on Train. I can double check.
And if not, we could always, if you provide us with your email address, we could send you the slides used for that.
Right.
Thank you, Candy.
Other questions? Okay. As always, more information about the core competencies can be found through the core competencies section of the council website or by sending me an email. And I'm going to go ahead and drop my email in the chat one more time. And with that, Bill, I will turn it back to you.
Thank you so much. Thank you, Mayella. Well, haven't we been efficient today? Let me ask if there is any other business that members believe should be brought before the council before we adjourn.
And Bill, I believe that Terry has asked for a moment. Our NACHO representative.
Well, thank you, both of you. Yeah, just a brief announcement from NACHO. Last week, NACHO released its latest national profile of local health departments. And this is based on the 2022 survey of our roughly 3,300 health departments in the nation. 146 pages. It's on the NACHO website. You can download it. Deals with a whole variety of profile issues around local, such as financing, leadership, workforce, staffing, public health preparedness, accreditation, public health policy, programs and services, and a new section, which is a particular interest. It's a section on harassment against local health departments, which is actually interesting reading. So again, it's on the NACHO website. And for those fellow public health geeks, it's and actually for those who don't identify as public health geeks, it's interesting reading and can be a valuable resource in planning, in public health planning. So thank you.
Thank you, Terry.
And Bill, we see that Dr. Gilmore is back.
Is he?
If he maybe wished to continue on the question he was asking about the academic health department learning community activity.
Well, thank you, Ron. My only question, I don't know what happened, but it occurred and interrupted the question. But in actuality, I'm one who plans ahead, far ahead. And my question actually had to do with the APHA meeting being this year in the Twin Cities, welcoming you to the Midwest. If there is planned to be a session regarding the update on the academic health department approach, as you typically have had in the past. And I don't know if that's on the docket or not, but I find those sessions, those updates really extremely helpful and important. That was my question.
So we will have a council on linkages session as we normally do at APHA, and we are in the process of kind of determining the focus of that session. But we're also planning to submit additional abstracts for APHA by the March 29th deadline. And so we can definitely plan to submit one about what's been going on with the AHD learning community.
Thank you.
Yeah, and Gary, we've been hearing many requests for convening people. And we're struggling, frankly, with exactly how and where, and maybe multiple places where we try to convene people, because we know, a lot of practitioners don't go to APHA, but a lot of practitioners do go to the NACHO annual meeting. So we're just trying to figure out a good way to do this that brings the academics and the practice folks together. So more to be brought to the attention of the council as we find venues. Although I think there is a venue, Minnesota.
Yes, so we, through the Academic Practice Linkages in Public Health Caucus and the University of Minnesota, we are planning a joint roundtable session on academic health department partnerships. We don't have much information at this time, but as that develops and we have more information about how to register and sign up for that event, we will definitely make sure that we share that with all of you.
Thank you for those updates. Greatly appreciated.
And Bill, I see there's another hand up. Karen? You are on mute if you're trying to say anything, Karen. I'll try one more. I'll send Karen a chat just in case. Well, Dr. Keck, back to you.
All right. Well, I think that brings us to the end of our session today. If there are no more comments. Remind you that the next council meeting is scheduled for June 24, starting at 2 p.m. Eastern Time. So again, as we've said many times, if you have any questions about that or really anything else related to the council or this session, please contact Mayella to begin with. And we'll do our best to get information back to you. I'll just pause for a moment to see if there are any other questions or if folks who started to speak would like to come back on. Well, it is Friday afternoon after all. And so I thank all our presenters for being concise and direct and informative. I think we are ready to terminate the meeting. So let me declare the meeting adjourned. Wish you all a good weekend and a happy spring that is coming quickly, I think. Till next time then. Thanks. Bye-bye now.
Bye-bye.